Okay, so to get this week started, I'm really excited that we are going to be looking at a topic which we don't usually talk about in cardiac MR, which is looking at electrical activity with the assistance of MRI. So, as we all know, MRI is great for looking at anatomy and function. We can understand, looking at the health of the tissues through tissue characterization techniques. But one thing that we're not super good at is looking at the actual electrical activity of the heart with MRI. So we have two really interesting papers. So the first one is going to be presented by Dr. George Joy from Bart's Heart Center in London. He's also a member of the Institute of Cardiovascular Science at University College of London. And he's going to be talking about how we can do imaging-guided electrocardiography with the assistance of CMR. And then after Dr. Joy speaks, we're going to move to Dr. Petra Albertova from University Hospital of Würzburg. And she's going to talk about kind of a new sort of contrast called rotary excitation. It's not really new, but it's something that's kind of popped up again in our field of study, which may allow us to capture the presence of magnetic fields, very small ones, in tissue, which would potentially allow us to look at cardiac, direct detection of cardiac conduction. So we'll move to her in the second talk. So with this, I'm going to hand over to Dr. Joy, who will be doing our first presentation. So you can go ahead and share your screen if possible. You make sure, yeah, you should be able to. And take it away.
Thank you very much. Can everyone see my screen?
Yes, can you make your screen, make the PDF full screen? That'll be a little easier to see. Okay, perfect. Yes, that is great.
Great. Thank you very much to the Journal Club for inviting me to talk. It's a real privilege to be able to share my work with you and the work of my team. So our study was really looking at pro-arrhythmic substrate in hypertrophic cardiomyopathy, which we hypothesized to be related to structural change. And we know this from basically small invasive studies and also ex vivo studies as well in HCM. So we wanted to exploit the ability of CMR to perform advanced tissue characterization to really go into this a lot further. So what we know is that individuals with overt HCM and a sarcomeric mutation have a higher risk of sudden cardiac death. And in subclinical HCM, those with a sarcomeric mutation but without hypertrophy have an increased risk of progression to overt disease if they have an abnormal 12-lead ECG. So we wanted to look into this further, and I will show you my my first figure. So this is our technique, and I really have to credit Dr. Gabby Kapter for inventing the reusable ECGI vest. She is the inventor of this device that really enables us to perform ECGI at scale. So the way we approached this is we scanned 70 individuals with subclinical HCM and 104 individuals with overt HCM, and half of overt individuals had a sarcomeric mutation. So what we do here is we apply Dr. Gabby Kapter's vest onto our participant to record a 256 lead ECG. We then use a mirror vest with identically positioned fiducial markers, and we acquire a dark blood 100 slice stack, which is about 3 minutes of free breathing acquisition. And this enables us to obtain heart torso geometry. So using Prof. Rudy's computational techniques to apply the inverse solution, we're able to obtain activation and repolarization time from 1,000 computed epicardial electrograms and activation recovery interval, which is just the difference between these two intervals, which is a surrogate for action potential duration. And what we obtain are these epicardial maps, essentially. So these are activation time maps. These are activation recovery interval maps, which is a surrogate for repolarization duration. For global epicardial conduction recovery, and also by examining neighboring computed electrodes, we're also able to detect small spatial differences in epicardial activation and repolarization. So in the interest of time, we'll move straight into our findings. So essentially, this is our subclinical HCM, an exemplar. So what we found is in subclinical HCM, in the complete absence of hypertrophy, we detected a slowing of epicardial activation, and this sort of persists in overt disease. In terms of repolarization, subclinical HCM have a normal repolarization duration, but in overt disease, repolarization is prolonged. Importantly, these changes that we see in subclinical HCM are present even in the presence of a normal 12-lead ECG. So moving on, what we can see in subclinical HCM, actually, even though the repolarization duration is normal, we find large gradients, which suggests a high spatial repolarization heterogeneity. And this, again, is not something that we can detect using conventional techniques and using the 12-lead ECG. Moving on to overt disease, we found that those with a sarcomeric mutation had a higher incidence of fractionation of their epicardial signals. And importantly, this is present even in the absence of scar and even in mild hypertrophy. So just to have a bird's eye view of our findings, we show that in subclinical HCM, epicardial activation is slowed and repolarization is more spatially heterogeneous, and this is even in the presence of a normal ECG. In overt HCM, we see that while conduction remains slowed, repolarization is prolonged, and importantly, there is a difference in those with a sarcomeric mutation who have more fractionation. What we also found is that conventional markers of risk in HCM, such as SCAR, NSVT, and severe LVH, were also related to abnormalities that we find using ECG imaging. So we thought our findings were reasonably important because it's showing for the first time that we can really detect the earliest changes, electrical changes of HCM. And in overt disease, we have a quantifiable risk marker that tracks conventional markers of risk and may in future help us potentially in terms of decisions, particularly with sudden cardiac death, exercise prescription, ICD implantation, but particularly our results are important in subclinical HCM because of our ability to detect disease very early. And we have a moving landscape with novel myosin inhibitors and novel therapies coming through with HCM. So these are my main findings. I hope the timing was okay, and I'm happy to field any questions you may have.
Awesome. That was perfect timing. Thank you so much for presenting this really exciting paper. So I'm going to open this paper up for questions. So if anyone has a question, you can feel free to type it in the chat, or you can unmute yourself or raise your hand and I can call on you and you can ask your question yourself. So while our audience is thinking about questions, I have some questions more about the technique. And so, if this is something that's, not really in the scope of the paper, you can deflect. But can you describe which information is coming from this vest, the eye ECG, and which information is coming from the CMR exam? So, it looks like you have kind of spatial information coming from both, but how are those complementing each other in this particular method?
Yes, so the initial vest that we use really just is like a normal clinical 12-lead ECG, except it's 256 leads. They're all unipolar. We don't really get any spatial information. The spatial information is all from the CMR, but this is purely for heart torso geometry. We don't get any electrical information from the CMR. It's just to apply the inverse solution of electrocardiography.
Got it. So you're picking up electrical information at the leads and
Yes.
then using the CMR to localize where that information is coming from.
Yes, exactly.
Got it. And so this actual vest that's in the MRI scanner, this is not the same vest. It's just a vest with the same structure, so that you can kind of map where the different leads are picking information up from.
It's not the same vest, no. We have to be quite careful when we apply this mirror vest that contains the sort of MRI opaque fiducial markers. We have to be quite careful to make sure that they're in the same position as the ECG vest that Dr. Capter's recording vest. So that's a challenge that we are hoping to overcome with time. But for now, we do need the sort of MRI safe vest to go in the scanner at the moment.
Okay, so if there's no questions now, I'm going to ask another question. So, is this vest meant for like research purposes, or is the idea that eventually this could be rolled out to patients coming in for any CMR exam, where this information would be useful?
Yes, I think for now, we are still quite very much in the research sort of domain. What we need to do is really perform a very large scale study to see if this does inform us on who's at risk of ventricular arrhythmia down the line, who's at risk of progressing to overt LVH. I think our current technique is using imaging surveillance and a 12-lead ECG. And a 12-lead ECG, it's quite difficult to define normal versus abnormal. It's quite difficult to quantify abnormalities. So I think further work is needed, but definitely the goal is to roll this out into the sort of the clinical care realm.
All right, and just a follow-up question to that, because I think it's related. Um, you know, I think this vest is an incredible tool, and it provides a source of information that is totally different than what we can get with MRI right now. But could you envision a way where we can use the information that's gathered by the ECG and come up with an MRI surrogate for that information, so that we can skip the vest portion and try to capture that same information just with MR? Or do you think that is just beyond the scope of what MRI is capable of?
Yes, I seem to think MRI has sort of limitless capabilities, and with the other wonderful work that's going to be presented, I hope that we can map electrical potentials using our MRI. But for now, unfortunately, it's applying funky vests and seeing what we can find. But we have applied this technique to several other pathologies and found interesting EP abnormalities that seem to co-register with SCAR, particularly in ARVC and myocardial infarction. But what we're really trying to do is focus on early disease to sort of target people at an earlier stage of their phenotype to sort of prevent progression of disease.
All right, I think there is time for one more question. I've been dominating the questions portion here, so if anybody has one, now is a good time to ask. All right, if not, then thank you again, Dr. Joy, for joining us. I know you have to run to get back to your patients, but we really appreciate the time that you've spent with us. So at this point, we will switch gears. Oh, is there somebody?
Can I ask one?
It sounds like maybe we have a question, but the sound quality is not so good. I think Vic is trying to ask a question. Vic, if you can hear me, if you could type your question, that might be better, because it's hard to hear you. Just gonna type in case. I think Vic is having some technical difficulties, it sounds like. Okay, I think I'm going to, I think we're going to unfortunately give up, which is too bad, because I'd love to hear the question. But maybe he can ask it in the chat, and I can send it on to you, Dr. Joy. I'm going to mute
Thank you.
Vic at the Good. So again, we're going to switch gears now to Dr. Petra Albertova from the University Hospitals of Würzburg, and she's going to talk about some work that she and the group there have been doing to potentially
Nicole,
have. Oh, not sure what's going on, but we'll see. Okay, so work that that they're doing in Würzburg to potentially directly acquire information about recurrence in the heart. So I'm going to hand over to Petra for her presentation. Oh, Petra, I can't hear you. I wonder if anybody else can hear. No, okay. No, I can't hear you still. I'm still not hearing you. No. Uh-oh. All right, if Vic is there and wants to ask his question while Petra is figuring out her her sound issues, maybe we can do it now.
Nicole, can you hear me now?
Yes, we can hear you now. Awesome.
Awesome. I typed it into the chat. It looks like it went directly to you, but that's okay. And forgive me because I missed part of George's presentation, and this is a really fine body of work, really exciting, especially for people that are interested in cardiomyopathies of various sorts. But I was wondering if he had a chance to use it yet on apical HCM.
Hi, Dr. Ferrari. Thanks so much for your question. I think that we are planning to use it on apical HCM. I have some theories about what we'll find, though, because we have those very deep T-wave inversions.
Yes.
And some of our patients did have apical hypertrophy, and we found, particularly in the apex, this very prolonged repolarization that was quite focal. So it's quite an exciting area, and we're hoping to explore it in further depth. But my feeling is that apical HCM and apical LVH is associated with very prolonged repolarization.
It's always interesting, George, because as you know, many of the patients with apical HCM will go on to develop an aneurysm of the apex, and your group has shown very nicely, Gabby, I think as well, that there is ischemia at the apex and an abnormal vasodilator.
Oh no, Vic, we've lost you again.
Perfusion.
Oh, you're back.
And
okay.
the relationship between, it would be very interesting to know what the relationship is, George, between the electrical abnormalities and then the remodeling stimuli for aneurysm formation, and whether it relates, in part, and maybe predicting the microvascular dysfunction or ECG abnormalities related to perfusion abnormalities. So that's a long-winded answer to say it's very exciting work, brilliant work, and congratulations on some very nice work.
Thank you very much, Dr. Ferrari. I look forward to catching up in Washington, hopefully. Yeah, we're really interested in apical LVH, particularly as the aneurysms confer an increased risk to sudden cardiac death. So excited to hopefully in future share some findings in that subgroup.
Okay, perfect. So at this point, we're going to see if Petra can, yes, fingers crossed. Let's see.
Let's see, do you hear me?
Yes, perfect. Okay, we can hear you. Awesome.
Always
okay.
the same thing. Okay, then I will start to share my screen. I hope, oh, that's the wrong screen. Okay, can you see my screen?
Says you've started screen. Yes, now we can see it. Perfect.
Okay, just a little late. Okay, so thanks for the opportunity to talk here and to present the work of our group. And what we're working on has already been told. We generally try to detect biomagnetic fields via MRI. And this is kind of interesting because usually, biomagnetic fields occur in the body wherever electrical conduction takes place. So this means typical examples are, for example, the muscle, the nervous system, or the brain itself. The strongest source of biomagnetism, however, is the heart, which will be the topic of this talk. Usually, the biomagnetic fields are detected using magnetoencephalography or magnetocardiography, and all of those use sensors that are highly sensitive, typically squids or OPMs. Let me just switch to this proportion. However, all of these methods have a very limited spatial resolution due to the inverse problem they need to solve. And that is an issue because if you want to plan intervention, for example, for epilepsy or disordered cardiac conduction, you need to localize the error or the way the electrical conduction takes place. So the question is if we can solve this issue by using MRI, which has intrinsically a higher spatial resolution than the other methods like magnetocardiography. So far, as you know, MRI is not established for detecting biomagnetic fields, and the question is, why is that so? And there's actually two reasons for that. First of all, biomagnetic fields are in the low frequency range, meaning they are in the Hertz range, whereas the resonance frequency of clinical MRI systems is in a megahertz range, very far off the Hertz range of biomagnetism. So we cannot use the typical resonance effect we typically employ in MRI. The second issue, and that's the reason why we can't use phase sensitivity, is that those fields are very, very small, meaning that we can't use phase MRI to detect those fields because they are tiny and also partly oscillating, which causes the phase to cancel out. However, in 2008, Witzel and his group proposed a very interesting idea of how to change MRI sensitivity into the low frequency range to detect biomagnetic fields. And to do so, he proposes to use a spin-lock pulse. Spin-lock pulses are typically used to detect T1 row and T2 row relaxation times, which we won't do here. We will just simply use the property of the spin-lock pulse to introduce another resonance frequency to our system, which we can in fact tune, and also we can fix it to the low frequency hertz, just like the biomagnetic fields are. This method has in fact already been used to detect neural biomagnetism, for example, in epilepsy and alpha activity. But so far, the method has been limited to purely oscillating or sine-like magnetic fields. And we asked ourselves whether it is possible to generalize this method to peak-like or pulsed magnetic fields, since most of the fields of the body are not oscillating in nature. So that's where we come from. Let me quickly change the first image. So in this first figure, you can see the sequence we use for rotary excitation detection. So REX is short for rotary excitation, as was already mentioned. And it is, in fact, quite simple. So we start with an adiabatic 90-degree pulse, which tilts the magnetization into transverse plane. Then we apply a spin-lock pulse. A spin-lock pulse, for those of you who have never worked with spin-locking, is nothing too fancy, in fact. It's just a constant amplitude pulse with the LAMO frequency being its carrier frequency, and the phase is chosen such that it is collinear with the magnetization at all times. That's all. And after the spin-lock pulse, we crush the transverse magnetization by strong pressure gradients, and then basically you can employ whatever readout you want to. We typically use spiral acquisition, either single shot or interleaved spirals. The interesting part actually is what happens during the spin-lock pulse. And to explain that, I want to show the video you can find in the supporting material. Can you see that? Okay, perfect.
Yep.
So up here, you can see the magnetization trajectory for different interaction timings. So down here, let me just start the video quickly. You can see a stimulus that is sync-shaped in this case. And hopefully it's going to repeat in a second. As soon as the pulse starts, the trajectory or the magnetization is tilted away from the X prime axis. And therefore, let's see it one more time. We will have like a tilt of the magnetization away from this axis. In fact, the exact trajectory depends on the timing of the stimulus regarding the spin-lock pulse. So since in most experiments we won't be able to control or tell the interaction timing, we will therefore repeat the experiment several times at different interaction timings, and then calculate the standard deviation of those images. So we are imaging purely the Z component of the magnetization after the spin lock interaction. And only in case of a resonant interaction, this tilt will take place, the rotary excitation, as we call it. And if there is no stimulus or the stimulus is tuned off resonantly with regard to the spin lock pulse, no tilt will take place, and also therefore every repetition of the experiment will give the same result and standard deviation will vanish. So the standard deviation is in fact our measure of the field. Okay. So this figure nicely illustrates why we're talking about resonance effect. So in the first column, you can see 3 different stimulus types, sine function, a sync, and 2 different Gaussian pulses. The second one is not too intriguing. It's just a Fourier transform giving us the power spectral density. And we know that a 50 Hertz sine has maximum power spectral density at 50 Hertz. That's not too intriguing. But what is interesting is that the Rex response spectrum, which is the Rex response depending on the spin lock frequency, which we can just set here in the range between 0 and 200 Hertz, closely resembles the power spectral density, meaning that if we have a high power spectral density, we can also have, or we also get a strong Rex response. So the Rex amplitude is increased, and that's why we are talking about a resonance effect in this case. So those simulations were performed neglecting relaxation times, but we can also do the same thing using the relaxation time of the phantom, which we will look at in a second, or the tissue parameters of the myocardial tissue. And even though the response is kind of distorted, we can still tell that there's a Rex response for stimuli, in this case, a sync stimulus. So the natural next step after the simulation tells us it might be possible to detect those fields is to try this in a phantom setup. And that's what we did. We used a spherical phantom, which is filled with a gel. And in this case, we can control the interaction timing very nicely, which helps us to interpret the results. So in the first row, you can see that the contrast is actually just as we would expect according to the magnetization trajectories we looked at earlier, is changed with interaction timing. And if we plot this, we can actually see that the relationship is sinusoidal, just like we would expect. So in this case, because we do know the interaction timing, we can simply fit a sine function to every voxel in this case. But in most cases, hopefully in future, when we start to detect real biomagnetism and no artificial fields anymore, we can detect the fields calculating the standard deviation, because this does not need any further assumptions on the timing. Okay, and also the last proportion of theoretical part is that we can detect those Rex response spectra, which I talked a lot about up till now, in the phantom setup as well. And I think the results very nicely resemble the simulation, which lets us hope that this might work for cardiac fields as well. And that's what we're gonna take a look at now. So let's come back to this image. So let's talk now about how we can change this method to adopt it for the detection of cardiac magnetic fields. In this case, we're talking about the QRS complex. So there's 2 main differences. First of all, the stimulus looks kind of different because it is a QRS complex. That's not too difficult because we can just like adapt our sequence to that. But the bigger issue is that the timing of those fields is not in our hands. We cannot control it. Therefore, we plan to use every second heartbeat for detection, meaning that we use 1 R wave to start a trigger, which starts a constant delay. This delay will be set to the average RR interval of the subject, such that we hope that the next QRS complex will fall within the spin lock duration, and we can have this resonant interaction between magnetization and the stimulus field. We've performed standard ECG measurement on a subject with breath instructions to see how much the RR interval in fact varies, and we will use this later on. But what's visible here as well as like the the gray background indicates the regions where the RR interval varies so much that the QRS won't match the timing of the spin lock pulse anymore. So we won't be able to use detections of those pulses. Okay. So next up, we performed an optimization for the QRS complex because it is a different pulse shape. And we found a perfect set of spin lock frequency and spin lock duration to obtain maximum Rex amplitude in this case. And to prove that we actually detect the QRS field and the Rex amplitude indicates this very field, we need a control measurement. And in the heart, we cannot just simply tune off the stimulus field as we would do in a phantom experiment. Therefore, we need a control measurement. And this control will be performed with an off-resonantly tuned spin lock pulse, at which the Rex amplitude should vanish. So that's what we did. We tried to resemble the in vivo experiment as closely as possible. We therefore used a phantom setup, a phantom filled with bovine serum albumin, which has relaxation times that resemble the myocardium. Also, we used a stimulus shape that was chosen according to MCG data. We used the timings of the ECG we recorded and amplitudes of the field, which are realistic according to simulations. So that's the field amplitude right in the heart, and it should amount to around about 40 nanotesla. And what we found is that the Rex amplitude nicely increases in a linear fashion with a stimulus amplitude, and also the detection is significant for all the fields we tried. So we tried QRS pulses with durations between 80 and 120 milliseconds, and we obtained a high statistical significance for the detection in all cases. However, in figure B, you can see the P value maps. And there you can see that there are certain regions where the P values are not so good. So the detection didn't work too nicely. And the reason for this is that those are the regions where the main magnetic field strength deviates from its nominal value. And we can see that this is like a main issue we need to tackle. So that's our takeaway, actually. With these experiments, we are left hopeful that this might work. In fact, however, before we can perform an in vivo experiment, we first need to adapt the sequence or change the sequence such that it won't be as sensitive to magnetic or to inhomogeneities of the field anymore. That's what we're currently working at. And also the step to an in vivo setup is quite a large one. Therefore, we are currently working on a cooperation with a group that is very much experienced with working heart models and MRI. And in this setup, we could have real cardiac magnetism while not having any motion and any blood flow, and quite controlled conditions for the experiments. For example, we can also perform detection over quite an extended period of time. So we are quite excited about that, and let's see whether it works or not. And with that, I didn't skip to the last slide. I am open to questions.
Awesome. Thank you so much, Petra. This is really crazy work. It's amazing that you're able to detect such teeny tiny fields this way. So I'm going to open this paper up for questions. So again, if you have a question, you can type it into the chat, or you can raise your hand or unmute yourself, and we will make sure you get your question asked. Okay, so maybe I will ask my question first. So, I think one of the things that I have a hard time envisioning with this work is, what would you envision the final product being? Right? Would it be very similar to what we saw from Dr. Joy, which would be like a three-dimensional kind of activation timing map, or what would you like the end product to be?
Yes, that's actually quite a hard question for me. Still a very interesting one. So we definitely would envision something like that. Our main selling point is the high spatial resolution, but at the same time, I must say that this method has a rather low temporal resolution. So we might be in future, that's something we're also taking a look at, find information about the exact shape of the stimulus by something like a fingerprinting approach. However, the temporal resolution is quite limited. And so in the next step, having the high spatial resolution, we would need to model the electrical conduction and find how to match magnetic field to the electrical conduction. And from then on, we will pass it on to our fellow physicians who know a lot more about the heart than I do.
Any other questions before I ask another question? Okay, I'm going to ask another question then. So how, I mean, I know you looked into this, but it's still something that, like, I'm kind of trying to wrap my brain around. How sensitive is the final, kind of RAC standard deviation map to the actual shape of the stimulus? Because, like, as you say, you don't know really the timing, you don't necessarily know what the shape is going to be. Like, would you run into problems, just from, deviations due to pathology, or, how exactly do you need to know that?
So I guess in our first experiments that we will perform hopefully anytime soon, we will perform a REX resonance spectrum, or we will try to acquire that. And this way we are not too sensitive to the exact shape the magnetic field has, because that's like such a true point. We don't really know how the field looks like right inside the heart, because like that's the main difference between all the other methods and our method, is that the sensors are not far away, but the MRI method kind of uses the spins right at the location to detect the field. And there is no way to find the fields right in the myocardium. So we don't really know so far, but that's like an intriguing question we will definitely need to tackle.
Awesome. Thank you again for introducing this reintroducing this crazy concept for detection of very small fields.
Thank you, and sorry for the technical issues.
No, we got it sorted out. That's perfect. So with that, I'm going to hand over to Matthias to talk about what we have in store for next month.
Hi, I hope you can hear me. I will share my screen here. We will stay with hypertrophic cardiomyopathy, and will next month go more clinical, actually present 2 papers, and I'm thankful for Reza. After we had already the first paper, he agreed to present his paper actually while we were here at the Journal Club. So we will hear from his group on a paper in the JCMR, accelerated myocardial fibrosis in young to middle-aged patients with hypertrophic cardiomyopathy, and then go to a paper published in JACC from Theo Karamitsos' team, meta-analysis on the quantitative LGE, CMR, and sudden death, which is very important for clinicians. There has been this 15% rule, and we will hear more interesting stuff, and we'll learn probably that 15 was not the best, but maybe 10% was it. So exciting, more on a clinical side, like almost a continuation of what we heard today, what's in the pipeline on the technical side. So I'm looking forward to seeing you all there, and be well, and until November 6th then.
Awesome. Thanks, everybody. Have a good day.